Welcome to QD Clinic, brought to you by RoomNow.live. Guess what's free? RoomNow.live is free if you register for online participation. So registration's free, learning is free, participation in the polling and the sessions are free, and the downloads are free. It's there for you to take. Today's case is when it's not rheumatoid arthritis, what is it? A 67-year-old white fellow comes to see me for the first time. He's coming as a second opinion consult. He's been treated by another rheumatologist for the last 4 years with a diagnosis of seropositive rheumatoid arthritis. At that time, he presented with pain in his hips and his knees, later spread to his fingers and feet, he says, with swelling. And he did have an elevated CCP antibody at 160 units, but a negative rheumatoid factor. X-rays were done repeatedly, did not show any evidence of erosions. He's been treated largely for the last 4 or so years with methotrexate. Says he's done relatively well, but he intermittently has to take steroid pulses or bursts for 2 or 3 weeks for his flares. He's had a problem in the last few months in that he's had carpal tunnel surgery on both hands. He's had a few flares. His other doctor is toying with giving him a TNF inhibitor or tocilizumab as an infusion, and he comes to me for a second opinion. So when I see him, he has a number of tender joints. In fact, he's got 13 tender joints, no swollen joints, and he has a CDI score of 38. He's got a really high HAQ score and a 9 out of 10 pain score. And but really nothing to show for rheumatoid arthritis, even though he's done really poorly and says that, well, now he's on 5 milligrams of prednisone. He was on 15, then 10, now he's on 5. He says last week his MCPs were all swollen up. Okay. So, but I don't see any evidence of rheumatoid arthritis. So the question is it rheumatoid arthritis or not? And the rules on managing these kind of cases is if you really doubt the diagnosis, first thing to do is nothing, meaning give the patient time. You might need to see them 2 or 3 times to make sure that they're not going to have synovitis, especially if you start to withdraw therapy or try to restrict the use of steroids. Second, you want to look for sequelae of inflammation, meaning if this person has had repeated, chronic, intermittent, long-term inflammatory synovitis, there should be some sequelae, meaning he should have what? Limitation of motion, contractures, evidence of deformity, or in the least, X-ray evidence of joint space loss and erosions compatible with the diagnosis. And lastly, you might want to look for laboratory evidence of inflammation. We're doing that at this visit, although past labs have not shown him to have a high ESR or CRP. So forget about this case. We're going to see what he has, and we're going to just continue his methotrexate for now. He does not merit, more aggressive therapy. I want him to be off of prednisone. I'm going to slowly wean him off his 5 milligrams, and I'm going to treat him for pain and sleep problems. And I'll tell you my experience with these kind of cases. My experience with, I have to have a few thousand of these kind of cases, is that when I don't think that they have rheumatoid arthritis, I'm right 80% of the time. Meaning that if I withdraw therapy, or slowly wean them off therapy, I'm going to be wrong 10 to 20% of the time. Meaning they're going to flare up, they're going to show synovitis. I'm going to eat crow and reinstitute anti-inflammatory or DMARD therapy. But 80% of the time I'm right. And so when I'm right, what was it that they really had? Very common is they had osteoarthritis or inflammatory osteoarthritis. Most of them actually have fibromyalgia and a sleep disorder, along with an other arthropathy, usually osteoarthritis. This is more common in the elderly. So pain that gets amplified, pain that doesn't respond, is often pain being driven by poor sleep, fibromyalgia, myofascial pain disorder. Uncommon are other inflammatory arthritides, specifically truly inflammatory erosive OA, or palindromic rheumatism, which can be intermittent, as you know. Not sure I truly believe in that diagnosis of palindromic rheumatism, but I've seen it enough where I'll keep it on the list. Uncommon, less than uncommon, or exceptional are actually other inflammatory arthritides like masquerading or being called rheumatoid arthritis. That would include psoriatic arthritis, a peripheral spondyloarthritis, even polymyalgia rheumatica, the occasional undiagnosable, undifferentiated inflammatory arthritis, or idiopathic, meaning I have no idea arthritis. Don't use that term, but it's on some lists. Very rare, these cases were actually reactive arthritis that went into remission, or IBD or enteropathic associated arthritis that ultimately rears its ugly head. And almost unheard of is a patient called rheumatoid arthritis when in fact they really have another autoinflammatory, sure, but really another autoimmune disease like scleroderma, lupus, myositis, those sort of things. So most of these really do turn out to be degenerative disease with or without sleep disorders. Some will actually have inflammatory OA, but I think that's where most of them go. So that's my experience with what it is when it's not rheumatoid arthritis. Be interested in hearing your thoughts. Tune in tomorrow for more QD Clinic.